All right, so going to go through, can everyone see? We're going to go through in this talk here talking about the disease, the diagnostics, both the non-imaging and imaging. And I think the non-imaging stuff's standard, but I want you to be aware of some things in there. So I'm going to kind of highlight the big things that occur that you may go, wow, that's kind of interesting to know about the free T4, what happens to it. And then we're going to go on to the treatment, talk about the methimazole, the I-131, the YD, and then a lot of times we get questions about post-treatment stuff and what owners should do, so you can kind of talk to them about that. So it's going to be hitting the high points on all of this, all right? So this one's an old slide talking about hyperthyroidism, and it's on the rise, and it just keeps increasing, whether that's because cats are living longer or if it's something in the environment. We're talking about some of those things that are in the environment. You left the taco stand.
I told them to be there at 8 when we're done.
Thought you were. So right now they're predicting it to be about 1 in 300 cats. There's no breed or sex predisposition for cats to get hyperthyroidism, although Siamese and Himalayans are less likely to get it. Okay? Yeah.
Is that only because you don't
Yeah.
see that?
No, it's as a breed thing, they're a little bit less likely to get it based on the statistics of it. So it's spontaneous. It's not having anything to do with something being secreted like TSH. So people and cats are the only two that are getting this spontaneously. It's growing inside. It's not a TSH thing. But on the other hand, we'll talk about the TSH test in a little bit because that would be a nice test due to the negative feedback. It doesn't work that well. I'll explain why. And then they're not having the immunoglobulins creating it, so it's not like thyroiditis. So again, for these owners that really want to know, well, why does my cat get this? These are the things that have been associated with it, and it's pretty much you can't get anything out of the environment. I mean, litter. It's like you want your cat to get hyperthyroidism, you don't use litter. I guess you can use yesterday's news, shred up little pieces every day, but most people are going to, and even then, if you don't use litter, then you really can't use canned cat food, no soy products, no flame retardants, which are in the bedding, all that stuff. So it's there. We're not going to be able to pretty much stop it if any of these or all of these are associated with it. I would have liked to see what would happen if you had cats on an iodine-deficient diet early on, but then you run into the problem that the diet just isn't good for cats to be on. That was what interested me the most.
Did you send something out about potential goiters or something like that in the YD?
Yeah, because it's going to be, absolutely. So because it's a process that's going to continue to grow, whether it's going to be giving methimazole or it's going to be YD, that adenoma, pretty much 98% of the time adenoma, it's just going to continue to get bigger. And so with the deficiency too, the rest of the tissue will also increase because it's starved for iodine. So you're going to have a proliferation of that tissue, which I'm just honestly waiting theoretically, and I'm sure it has to happen if the cats live long enough, is that at some point the overactive tissue, it gets to be so much that they're going to be hyperthyroid, it's going to rebound. That's what I'm thinking is going to happen. And you can't give them more food because that's just giving more iodine. You can't give them less food because they're going to continue to lose weight. So I think that it's good in that it'll be good for, like I said, certain cats, older cats, last-ditch effort. Cats, owners don't want to do it. I think there's some limitations, but it's a good choice to have it in those specific cases. All right, so on this, everyone knows the clinical signs going there, the fast heart rate, the arrhythmia. This one, though, is one to keep in mind where the apathetic hyperthyroid, where they actually are not acting hyperthyroid, they're acting the opposite, about 10% of them. So they're acting the opposite of hyperthyroid, and their T4 is high. And so you go, cat's looking hyperthyroid on the paperwork, not acting hyperthyroid. There is a subpopulation where they will actually have those signs. So don't rule it out just based on clinical signs. Okay? And then the thyroid carcinoma, which is about 2% of them. Right? So it's not that common, but it does occur. So on the heart, this is really interesting stuff in terms of the wall thickening of the heart, when they have that wall change, sometimes it's due to hyperthyroidism, sometimes it's not. So in the study that was done looking at it, the wall thickening, some of them went away, some of them progressed. All right? Might have HCM on top of it. So there's no way to know. On the contrary, every ECG abnormality in these cats went away. Hyperthyroidism was resolved. So this is something you can talk to the owner about and say, look, cat has a little bit of wall thickening and has an ECG abnormality. I tell you that the ECG abnormality pretty much is going to go away. The wall thickening may not. That's just, you got to wait and see. And of it, 10 to 15% of hyperthyroid cats develop heart failure. From what we do, when we do our echoes before they go into the room, we probably have about 1 every 2 months that's actually in heart failure, pleural effusion, and so they don't go into the room. Because once they go in, they can't come out, and so we treat their heart failure first, send them away. And that's really important on that. It's important to identify the cats with heart failure. It's also important as a baseline, because if a cat was hyperthyroid and then 2 years later they end up in echo, first echo, they don't know, was this wall thickening there, static, or is it, where was it? So that's why we do an echo. We do it, tell if they're in heart failure, and baseline for the record. So the kidneys, the high thyroid increases their GFR, the glomerular filtration rate. That's what's making those kidneys look so good. But that's what's also causing these kidneys to burn out so quickly. So they're revving the engine at 7,000 RPMs all the time. All right? The thing is, too, one of the, and I'm not going to really talk about it, about the hypothyroidism, but I'll talk about it here. A decrease in GFR associated with hypothyroidism is probably just as bad as an increase in GFR. And a lot of times these cats that are hypothyroid on blood but clinically look okay, they develop renal failure and think, oh, well, it's the progression of the renal disease which they had before. It is progressing faster because their blood flow to their kidneys is decreasing. And so what we've done now is we start to actually supplement them and get them into a pretty much euthyroid state after about 2 to 3 months, particularly if their renal values start to bump up and go a little bit azotemic. I'd encourage you to start some siloxane, get their T4 into somewhat normal level, do that for a few months, and then back off, and then kind of taper it down and let their normal thyroid function try and come back. But don't let it go where their BUN and creatinine are starting to go out of range, because having a decrease in GFR, a lack of blood flow, can really damage those kidneys. Okay? So what we do is when they're hyperthyroid, they have that increased GFR hiding the renal disease, so we decrease their GFR with tapazole to see what their true kidney function is. It's not always 100%. I can tell you we've had cats that they look good on their tapazole trial. We've had them on it for a month because that's what it takes for the GFR to normalize, is a month. So what you get in a month is what you're going to have after treatment. That's usually where but we've had them where they have some atypical response to treatment where they actually also have renal disease on top of it. Something else is going on. The T4 drops to the same level, but they end up in more of a fulminant renal failure, azotemia, clinical signs, PUPD. So it does happen. But we do that to try and unmask their renal disease to see how bad they're going to be so the owners are aware. Yeah?
Well, it always happens that most of the time the BUN and creatinine can be okay, but I see a low urine-specific gravity, which immediately makes my index of suspicion that.
Oh, and when they're hyperthyroid?
Yeah, when I do the initial blood work.
I totally agree with you. I think a lot of these guys, I always attribute it to, rather than it being PUPD due to the hyperthyroidism, pretty much assume that they have some component of renal disease going on. If they're urine-specific gravity. 1045 or above, I'm okay. Below that, they have some component of renal disease. I totally agree with you. And it's not that we won't treat them if they have renal disease. For me, it's more that the owners understand what they're facing afterwards. And if they have some component of renal disease, then if their BUN and creatinine climb up and their T4 drops below normal, those are ones that I'll say in a month, get them on some siloxane because we can't afford the renal damage. And they might end up having to actually give siloxane for a long term, as long as they know. Yeah.
She got treated for this and she was okay. And then about a year later, she developed a little tiny bit of kidney change. And I have her on like a minimal dose of something, and so she's just really pretty stable.
Yeah. Because that kidney stuff will really put them under pretty quick. It decreases kidneys and blood flow. Have it, they don't like it, and they don't do well. So we want to increase that blood flow to them. So I've had a lot of conversations with the owners about this and say they think that, well, they can be treated, and that's not the case. It's just as long as they understand and the expectations are met, then they're fine. They make the decision. We tell them what's going to happen, and then they move forward or they don't. So that's reason number one for the tapazole trial. Reason number two is concurrent disease, because we do find lymphoma in these guys. So that's part of the reason I push for a tapazole trial, get them on there, or something to reduce the T4, because if then they continue to vomit, lose weight, look elsewhere. It's not going to be the hyperthyroidism the problem, and it's a catch-22, because tapazole could cause vomiting too. So then you got to go, well, look, this could be the medication, but if you're going to move forward, or if you want to know if it's tapazole, we've got to stop the tapazole because of the vomiting, or do the ear drug, and if the cat's still having problems, they definitely got to look elsewhere, look in the abdomen for a cause for vomiting. So
when you screen them when they come in for the treatment, the iodine treatment, you do echo. You also look at the kidneys too at the same time? You don't usually.
No. The best way to look at the kidneys would be to do a nuclear study of GFR, because then we could really tell.
I mean, for that kind of thing, I wasn't sure if you...
Only if there's a reason for it. Only if there's something going on that's, hey, this cat's continuing to lose weight, it's well managed, it's been on tapazole, the vomiting just started, but the cat's been on tapazole for a year already and just started vomiting. Something else is going on. So then we'll look elsewhere, because we don't. I've had probably 50-50. Some owners, you tell them this, they decide, hey, we're going to go work up the lymphoma. Some owners say, we're going to treat the I-131, and then we're going to do the lymphoma after that if we're worried about lymphoma. It's been a split. So they got to treat the diseases. And I talk to them about it and say we can do aspirates before the treatment and then see if it comes back to lymphoma. I think the last one was we did aspirates and then we did the treatment. And then they would deal with it afterwards.
When you do thyroid treatment to supplement them with thyroid, are you looking for a certain level in the blood for the people?
Usually it's going to be, I like to see them above that 0.8. I mean, somewhere around 1 or 2. To me, though, the BUN and creatinine is more important. That's what I want to see them back into that normal range.
The other thing I want to comment about in terms of monitoring is I work for GDAD at Hemolife, and we do a lot of treatments for these guys post I-131, and we're seeing cats that are flat out after this treatment, and you check out their T3s, and the T3s are very low, and they do very nicely with 1 microgram per pound of T3 supplement. And that's not something that I know a lot of doctors are. We've seen really good results for these cats that are just kind of flat out, opposite of what they were before. And when you check the T3s and you put them on the supplement, it's a real big difference.
There's a T3 supplement.
Yeah. It's called cytomel. Cytomel is the drug, and it's 1 microgram per pound twice a day.
I think they need to get supplemented. I agree with you. Whether it's going to be the sloxine or it's going to be the T3 supplement,
Yeah,
they need.
Sometimes we'll just T3. Sometimes if the sloxine or if the T4 is low, we'll look at free T4 and the TSH to determine whether they need both sloxine and T3. But we basically treat them specifically for what their pattern is, because you'll see some of them on the T4s but only have low T3s.
Yeah.
So it's so it's important to check all those things, and if you're not really sure what to do, and this is shameless commerce, but our lab will interpret that.
So post treatment, they don't feel good, you might want to check T3.
You check T4, free T4, T3, free T4, TSH.
Oh, so basically a thyroid path.
Looking at all those different things. We'll talk about those, because I know that there was even a T3 supplement, any of that stuff. So we'll talk about some of these things, and I have to sit down and think about where those play into it. Is this a feline or is it a canine T3 assay? Is it feline specific? Or do you not?
I think T3 is T3 as far as I'm aware. The process that we use is it's not an RIA, so it's a eco-friendly process. It's like, I mean, when we measure TSH, we're actually measuring CTSH, but it works in cats.
Yeah.
Which it doesn't work so well in dogs because there's so many discordant results. But for cats, it's a valuable test.
Yeah, I'd like to know about the T3 too, to see if it's cat or dog.
The other thing about free T4 is that I read some things that said that it might not be accurate as we were hoping.
We'll talk about that. It's actually pretty interesting. We just had a case that was sent over for a thyroid scan that had a free T4 that was elevated at a normal T4. We'll talk about why that was. So on the blood work, the liver value changes on the hyperthyroid cats. The big thing about this is when you see that ALT elevation. They looked at about 500 cats in this DVM study, all of them with elevated liver values. None of them had liver disease. Okay, so it's a good thing to go, okay, you know what, yeah, the ALT is elevated, it's the hyperthyroidism, pretty much. Nothing's 100%, but you can pretty much say, worry less about that. Elevation ALT with hyperthyroid cat, around 600, max 600, 700, that's going to be the hyperthyroidism. Okay. The diet, and this goes back to the YD stuff, they've looked at the diet back in the 70s and did studies with short-term and long-term excess diet iodine intake and decreased iodine intake. And what they saw was it was a decrease in iodine intake led to a short drop in the T4 and then a rebound. But we'll have a lot more data now with the YD to look at that. Okay. Some other interesting associations. A lot of these cats have concurrent hyperparathyroidism. So they have a lower ionized calcium. They have a lower folate and cobalamin. This makes it all very tough because a lot of these cats have GI disease concurrently. So you're running a TLI cobalamin folate test, and you got to interpret it in the face of the hyperthyroidism. So keep it in mind. It's affecting the kidneys. It's affecting the GI tract. It's affecting the liver. It's affecting the heart. It's doing a lot of things. And knowing that with the heart, the ECG abnormalities, they go away. The ALT elevation, not important. The GFR, very important. Anything you're looking at with the bowel, and you get a TLI cobalamin folate, you've got to interpret it knowing the cat's hyperthyroid. So which things are important, which aren't. And now it's not known if it's a malabsorption or a hypermetabolism thing. The other thing that's just kind of an interesting one is PRED causes a T4 to drop in a euthyroid cat, but not in a hyperthyroid cat. Okay. They get a delayed glucose clearance, which it doesn't change after treatment. So you might have a little bit higher in terms of their glucose when you're checking it. The diabetic hyperthyroid cats take their fructosamine level down. Okay. This one, again, pretty important in terms of proteinuria. That has, if you see proteinuria in these cats, the hyperthyroid, no correlation to kidney disease. So interpret it in knowing both of these things. Okay, no association with renal failure development, and it will resolve post-hyperthyroidism. It has to do, again, with the blood flow to the kidneys and how much they're trying to push through there. It's just getting right through the glomerulus, and it's dumping into the proximal tubule. And then it's just hanging out, and they decrease that GFR, and you don't get that type of saturation. All right, chronic renal disease, they end up having a lower T4. Again, probably in that they're pushing a lot of blood through the urine clearance, and they're just the T4, they're clearing it out. So the T4 is getting filtered out there too. So then you got to go, well, in the lower T4, is it euthyroid sick, or do they have an increase in GFR going on there? Why is their T4 dropping when they have known hyperthyroid and the T4 is dropping down? Is kidney disease getting worse? Are they euthyroid sick? It gets to be a little bit complex. So talking about total T4 and free T4 by ED. So we're looking at the thyroid. The functional thyroid is really unbound T4 and T3. And euthyroid sick and hyperthyroid cats can have the similar amount of that free T4. So this happens, and I'm sure you've seen it, Free T4 by ED is abnormal. Total T4 is normal. That's a sick cat, most likely, not a hyperthyroid cat. They just had one that the T4, free T4 was out of range. It was like 55 or 60. The total T4 was normal. That's a euthyroid sick. That's what ends up happening. Their free T4 goes up. All right? That's kind of important take home, that they'll have, the euthyroid sicks will have an elevation in free T4. So the total T4 really is your best measurement, and you can have the false negatives. Those older cats will be in the lower 2/3 on their T4s. Okay? There's a diurnal fluctuation. So if you have a cat that's hyperthyroid, and you check it one time, check it a different time of the day, you still are suspicious of it because it will go up and down a little bit, and they'll go in and out of normal. The current disease, that will drop that T4 down. Something else is going on, and the higher GFR will lower it. So the free T4 ID, it's a very sensitive test. It's just the specificity is these group of cats right here, the euthyroid sick cats, have an elevated free T4. So again, if you see an elevated free T4 with an elevated total T4, it's a hyperthyroid cat. If you see an elevated free T4, normal total T4, it's probably euthyroid sick, something else going on. Does that make sense? Okay. The total T3 level is really, this is the problem with that test, and I remember it was in here, is that hyperthyroid cats will have this is screening for hyperthyroidism, not for supplementation. And I agree with you in terms of cats need something when they drop low, because it's really affecting a lot of their body. But the total T3 really is not one that's recommended, because a lot of the hyperthyroid cats will be in the normal range.
When measuring T3 normally is really more a measure of thyroid sick than it is ever a measure of thyroid disease.
The T3 suppression test, so this is some tests that don't really happen, and there's reasons why they don't happen. And the main one, I could go through all this, but this is the reason why this T3 suppression doesn't happen. Okay? So owner compliance on that test is going to be terrible, and then it's going to affect results. So it would be a good test, because you can get suppression. You can get suppression versus not suppression, but they fall out of this, and then it's tough to interpret that data. Asking them to do it 3 times a day for 3 days, pretty much, because you got to do 2 days and then 1 dose, and then bring the cat in. The thyroid scan? Yeah, that's the thing. We all know the convenience factor for owners, right? There's certain tests that they're like, why do you do this? Why do you do the thing that's more convenient? So you look at the total T4, free T4, still unsure, do a scan. TSH level. And so this is in the TSH assay in Europe, I believe there is a feline TSH. Do you know of that? Because the canine one, it's not picking all that feline, because it's specific for the canine. It sounds like for the canine it's not great. For the feline, it's just not.
It's actually really good for the feline. But we have the ranges calibrated, to the population of cats. Cool. So, but for canine, there's 30% results are discordant. When you get your results from Antec, it'll say right there. TSH is, you'd be much better spending your money on TGAA than on TSH, because TSH, just 30% of your results aren't going to match what's going on with the dog. And the cat is good.
Interesting. I'd like to get that from you, that data. Just that stuff.
Well, if you just read your Antec, when you have a printout, it'll say right on there.
Oh, on the canine, the TSH.
The reason is that 30% of regulation of thyroid production in the dog is growth hormone. It's not totally related to TSH, which is why the results are all over the place. Gotcha. All right. So there's a negative feedback mechanism. Again, these are adenomas, so they're producing. They don't rely on TSH levels in the cats, so they're going to feed back, and the TSH level is going to drop in the cats. And so what you're looking for really is that low level to confirm a hyperthyroid. A normal value probably rules it out, and that's what you're more likely to get, because if you're using a canine one, that's why it's interesting to find out if it's really it sounds like it's really good for cats. If you could use it, then it would be very accurate, because you could say, oh, it's low, then it's really the hyperthyroid, versus if it's normal,
then it isn't a hyperthyroid because you're getting that negative feedback. The problem becomes, the stuff that I looked at was because the cats don't pick it, it doesn't get picked up in cats because it's a canine, then you don't know whether it's going to be not detected if it's going to be low because it's a cat on a test or if it's truly a hyperthyroid cat with a negative feedback. So bottom line to that, from what I read, that's why I wanted to see that information, is if it's low, if it's normal, then it's reading the test appropriately and the cat is not hyperthyroid. Does that make sense? It's kind of rambling.
Overall, we use, I know we use just the T4 levels to diagnose hyperthyroidism, and it seems to work quite well.
Cool. All right, we're going to move on from that slide. Why the thyroid scan? Some people, sometimes they don't do it. Like Radio Cat up in LA doesn't do it, and it's really a business decision on that. It is. It's not a medical decision because you end up having to deal with license. Because is it needed? Yeah, it's needed because it helps really with determining how much you're going to end up treating in terms of dosage, if they have a thyroid carcinoma, or if they're even hyperthyroid. Again, it comes back to some of these cats with a free T4, they come in, they're high, the vet is worried that the cat's hyperthyroid. We do a scan, they're thinking that they're going to do treatment. So we scan those, they're not hyperthyroid. And so that's why we do that test. So we actually do, we kick probably one a month out and say, this cat's not hyperthyroid, go look for something else. All right, and then so we use it to confirm the hyperthyroidism, to identify the carcinomas because those guys need a higher dose, and then we use for treatment dose and predict failure because we can look at the size of them versus the background blood pool and say whether or not they need a higher dose. So this is for us, but it's interesting in that methimazole does affect our thyroid to salivary ratio. So off of methimazole, that's the cutoff for being a normal thyroid salivary. There's thyroid, there's salivary right there. So if this is 1.2 times brighter than that and they're off methimazole, they're above that, then they're hyperthyroid. No, this is really what they haven't been on at all. But if we had to do a withdrawal, it would be for 2 weeks because they have a rebound about 2 to 9 days. So we would say 2 weeks they have to be off. But usually we end up just doing them when they're on methimazole. And so we look at this and say, okay, if they're at 1.5 to 1 and they're above that, then we say they're hyperthyroid. And we do have some that actually come in close to that 1.5, and we say, look, we don't know yet. Just rescan it in 6 months. The other giveaway is if they're symmetric, pretty much the same size, then they're probably not hyperthyroid. So if they come in at 1.5 or 0.6, but there's 1 and the other one's pretty much gone, we know that it's going to be hyperthyroid because it's a negative feedback.
So your scan reads that, because otherwise you look at that, say that's 1. So your scan reads that.
Oh, no, usually I just put my hand up. Just kind of, yeah, we look at pixel values, absolutely. Look at pixel values and circle it and then find out. Yeah. So the thing is, the thyroid to salivary ratio is really good for determining whether or not they're hyperthyroid, but it's not really good because we can look at the two glands and say, all right, this one's overactive because that one's getting suppressed. That one's bullying that one. So we can look at that, but we can't really look at this and say, how much dose are we going to give? Because salivary glands can change depending on how much saliva they produce or what they swallow. So we don't use that for determining how much we're going to end up giving them treatment. So we end up doing, and I'll jump to this, which is that thyroid to back ratio. And there's the thyroid. And instead of looking at these, we look at the blood pool because the blood circulation is going to be pretty much consistent. And the more that they end up taking technetium into the thyroid, the less it's in the blood pool. So the number in the thyroid, the ratio just gets really more disparate, and they start to get really high. So there we're just doing it where we're measuring around that thyroid gland, and then we just put a known size around the blood pool, and then take that ratio again with the hand, just kind of going over it. So what we're kind of looking over the time in developing all this, what we really think is an optimal hyperthyroid evaluation, because we are seeing these falsely high, even T4 levels. They've been a little bit out of range, but they've not been hyperthyroid on their scans. But the free T4 is definitely, so you repeat that total T4, use your free T4 by ED, and then going into that thyroid scan and the clinical signs, and keeping in mind the apathetic hyperthyroid cats on the reverse. So those are really the tests. The other stuff we're not really about doing too much. So this thyroid to background ratio, we're using it as a predictor for treatment failure and deciding whether or not they get the 4 millicuries or 7 millicuries.
So what are you talking about, like background?
This background here, we're going to put a little circle over here, and we're going to just move it into the blood pool. That's just their circulating technetium in their blood, and it gives them overall an increase in activity. So, and that technetium gets taken up by the thyroid gland, by the stomach, and the kidneys. And so, but the thyroid gland is really the big difference because all the other cats has the stomach and the kidneys. And so if the bigger the thyroid gland, the more it's taking up of the tech, which then reduces their blood pool.
Okay, so it's kind of like the thyroid, and then the rest of it's kind of.
Yep. And the ratio goes up. And so we can use that. And the other thing is that as this gets hotter and hotter, these salivary glands get very tough to see. So methimazole side effects, we got them, seen them, a lot of cats get them. Facial excoriations, the vomiting, we'll kind of talk about doing the transdermal, trying that, give it a month. It takes at least a month for that to actually get into something that then you can look at again and say, okay, what's my dosage? Because it takes at least a month to get into that equilibrium of your blood pool and looking at your total, your T4. So I wouldn't check it before a month. They go on to transdermal. The big thing about the methimazole is that cats that just were put on methimazole versus I-131, they had a mean survival of 2 years, versus the I-131 cats had a mean survival of 4 years. The thing you got to understand in that is cats that have renal disease, underlying renal disease, have a mean survival of 2 years also. So if you end up with a cat that has renal disease, and then it's up to the owners in terms of the convenience, because the cat's pretty much got 2 years, whether you do methimazole or do I-131. Convenience. But if a cat doesn't have renal disease and the owner's like, hey, what's the reason for doing methimazole? It's not just a cost thing, because the cat's probably going to live more than 2 years, but it's also that methimazole is very toxic to them. There are cats, of course, that live longer than 2 years on methimazole, but what they found was that they do have side effects to it. Not only the inconvenience factor of the dosing, the daily dosing, but it is that it does affect them, their liver, it affects their survival. So I-131 really is a great treatment because it goes right to the eye, to the gland, and it hones in right on the overactive tissue. That's what makes it a really nice treatment. But it's an expensive treatment, I understand that. So this is where I was just talking about this renal disease and methimazole. Just keep it in mind, younger cats, they end up having this, it does affect their long survival. Versus the I-131. And the thing about this is that in this study, they looked at cats that went on methimazole and then got I-131, and they fell into this population. So, probably it's not good to put them at after 2 years from methimazole then to I-131. But they started on methimazole for a trial, they're on for 6 months, then they got I-131, they ended up having the longer survival. So this is, we've all heard about all this stuff in terms of the separating the foods, and you can't give them anything else. This is the one that I'm really interested in seeing, because these cats, if they're going to lose muscle mass, we're going to think, well, it's their kidney disease or it's hyperthyroidism, and it may not be. So keep an eye out for this. These cats go on YD and just start to really become gone, because they need that protein, and the protein dropping, the decrease in protein in the diet, 20%. On the bag it says 38%, but it's still below that level. It's the same as kidney diet, close to that. And what they ended up doing was they ended up seeing it when they looked at this, because the iodine's in the muscle, and so they had to decrease that to have the low iodine content. And so they spun it. Well, we're trying to be kidney friendly in these older cats. It's not true. I mean, you keep putting cats that don't have kidney disease, 10, 12 years of age, to a low protein diet. Those are really the population to look at and see if they start to have muscle wasting, because you don't want them to, and then I don't want you to think that that's because they're hyperthyroid or because they have kidney disease. The other one is that it has a higher carbohydrate level, so it's not good for the diabetic cats. Okay? But let me know, please let me know if you're seeing this. The term of it is sarcopenia, myopenia. Dr. Peterson, cat guru on the East Coast, just talking about this. But I still stand by that if you have the right pool, the patient pool, try it. See how it goes. Okay? Surgery for large carcinomas, for treatment-wise, and then with I-131, that's pretty much kind of standard. I'm not going to talk too much about these because they really don't work very well. There are some other things to try. This is an iodine blocking treatment, and it's been effective at treating mild hyperthyroidism. So if you end up with a cat that can't eat the YD, can't be on methimazole, isn't going to 31 therapy, I'll give you the name of this, and then you can send the owners down to Mexico. Because I don't think you can get it in the U.S. And then this one too, L-carnitine, but make sure it's L-carnitine. Again, just call me because that one is toxic. But it doesn't affect T4. You're just really dealing with the clinical signs at that point, how they're responding. So there are a few other treatments, but nothing really works that well. Mainstay is going to be, again, methimazole, the YD if they can hold, if they're going to be older, if the right population, or the I-131. So prior to doing the I-131, we'd like to get them on the methimazole, particularly if you're worried about concurrent disease, twice a day at a low dose. And then you guys are doing your CBC Chem, UA, and T4. And then we want to see that where the T4 is in the low normal, subnormal level, and looking at everything else. If they end up having an elevation in liver values when they're on methimazole, we pull them off because we don't drop the dose. Once they have that toxic reaction, they can't be on it. They got to get off. You can't, the transdermal, they'll still have the toxic reaction. Then we tell the owner, look, you don't really have many choices. You can go on the YD, or you can go for treatment because you can't really pull them off and then get them back on because their liver toxicity. They seem to just be predisposed to certain cats. And then if they end up having any penias of the white blood cell line, again, they go off, and we talk to them about I-131. And on any of those cases, we have a waiver that they end up signing and just saying, look, they understand that there's maybe risks afterwards, the main one being the kidneys, and we end up supplementing them with siloxane at that point to bring them back up. But we keep them off the toxic drug because the other stuff's really pretty bad. The liver toxicity, the white blood cells, the neutropenia, pretty much the lymphopenia, the neutropenia, anything that's affecting there. So these are kind of the things that when we're looking at them, that we look at in terms of are they okay for the waiver. If the urine-specific gravity is above 1045, I'll let them. So if they really want to get in, take a look at the urine. If it's above 1045, they can probably slide and do the waiver. Okay? And then they'll have to go through the tapazole trial. If they want to go on to the tapazole and they want to get a GFR study because they're really that crazy about what this cat's renal function is, I haven't had a single one do this yet, then we can do that. And at that point, they're on for a month. We can do a GFR study and look at that and say, yeah, this cat's going to be in the normal range. It should be fine after treatment. Okay? And it usually takes about 1 month, which, why is that important to you? Again, post-treatment, what you see is what you get after about 1 month. You'll kind of know where they are until their normal thyroid function comes back, but that's going to be kind of the trough is going to be about 3 months. If you're on your tapazole dose and you started treating them and you got your normalization for 2 months, I wouldn't expect that you're going to get any change in GFR after that. You put them on for a month, check it again after that, normalize. That's what their GFR is. All right, so it takes about a month for GFR to stabilize. So these are, again, the things, CBC Chem, pretty standard stuff. Radiographs, because we do have some of them that have masses in the chest, other things going on, and owners need to know about that beforehand. So whole body radiographs within about 6 weeks. Things that we do is probably the most important thing is, you all know, talking to the owner and making sure they understand what the outcome is, what to look for, because then they're never upset about that stuff. As long as they understand all what happened and then what are the potentials afterwards. Once they come in, we do the exam, and then the thyroid scan is done. Actually, the cardiac ultrasound is done first to make sure they're not in heart failure and to get the wall measurement. Then we do the thyroid scan to confirm that they're hyperthyroid, that they don't have a carcinoma. Then they get the I-131 treatment, and then they get to stay in a beautiful place that reminds them of Hawaii in that room for 5 days. Yeah.
Lots of love and attention.
A lot of hula stuff. So they just hang there. They seem to, I don't know, they seem to be all right.
For the most part, they do great.
Owners are more freaked out than the cats are.
Yeah, absolutely.
Actually, we watched one of our staff, that every time we looked at him, he was sleeping on the webcam.
That's all they do.
Every time.
There's actually a video that I run usually just of cats sleeping. And that's all they do. So the problem with the standard formula carry plan, which kind of went into favor around mid-1990s, is that the failure rate is it's higher. It's higher than it should be. There's that subset of population where the thyroid could actually cure with a higher dose, and that's what we're doing with that thyroid to background ratio. And it's only 4%, 4 cats out of 100. Yeah, but it's of those 4, you never know which. We know which 4, kind of, based on that big gland. So that's why when you have the data, if you're doing a thyroid scan, pretty much not to look at it and determine what your treatment dose is foolish. You're not going to treat a Chihuahua and a Mastiff with the same dose of Baytril. Why the heck are you going to treat big tumor, little tumor, same dose of iodine? It doesn't work. It's clear that there's a trend. In terms of the bigger the tumor, the more iodine they need. So that's kind of why this different dosing level is done. And I think we're the only ones really doing it. I mean, Broom does it. Broom and Tustin does different dosing levels. He actually puts them on an iodine-restricted diet for 2 weeks and then treats. So he really wants to get at that. He hates iodine, apparently. He hates the thyroid gland, I should say. Hates it. Will you ask?
So the point of the restricted diet is to make the thyroid more uptake.
Exactly. Yeah. So you restrict them from iodine, then you give them this iodine, and it all gets sucked right in. Yeah. But if the gland is too big and it's already sucked in all of it, and there's still some overactive tissue left, nothing to treat it with, they're a failure. And that's what we've actually seen what happens is on our repeat scans, because we do those, it gets the outside first. So blood flow in this whole thing has to be from the out in. It's not that we have a necrotic core to these thyroid tumors. It's actually that you have the outside takes up all the iodine. By the time it gets to the center, there's no iodine because they're just smaller. They're about 50% the size, whatever they end up being, but they're definitely small.
What happens to them in 4 years?
What now?
Kidney disease.
The iodine treatment said we give them 4 years. What happens after 4 years?
Well, they turn into pumpkins. They it's really that at that point they're looking at the population. The cats were usually around 14 average age, 18 being lifespan, so they end up dying from other things. No, it's not related to the treatment. No. You should have put that cat on Tapazole. He would have had he been 16.
I've had a couple cats who remained hypothyroid for quite some time after their treatment, like longer than 3 months.
Yeah, because some of them are going to be permanent. And so that's where I would either, so at 3 months.
I mean, I have months.
Yeah. And,
It's a tiny.
and that GFR, or the BUN and creatinine is really going to be that determinant. And I recommend all of you look at that. If the cat's able to handle that low thyroid and the BUN and creatinine are okay, then wait it out a little bit until you put them on supplement, because it usually takes 3 to 6 months for them to rebound. But if their BUN and creatinine start creeping up and they're getting out of range, I recommend supplementing them earlier. Don't let the kidneys go starve for blood. Yeah, so some will come back, some won't. So this is just showing what this background looks like. That's a 5, it's under 11, so we end up treating that one with 4 millicuries. That one's at 11. Anything at 11, around 11 or above, we treat with 7. And this is kind of the graph of the cats that we looked at, the 150 cats. There were outliers, but for the most part, of the 142 cats, I think 136 of them had their thyroid to background ratio here. And then of these guys, there were 8 cats, 2 there, and here, 1, and then they just started getting way out of range. These were the failures. So they have more cats for the population outside that thyroid to background ratio of 11. They were high. So it just proved what's intuitive, which is the bigger the gland needs more iodine. But it's never been proven. Everyone just got onto this whole 4 millicuries thing. Just do the treatment. And then they end up getting retreated, coming back. So this is just, again, those numbers. In terms of 6 out of 8 of them had a thyroid to background. These players greater than 11, 27 of 30 of them that succeeded with 4 millicuries had a thyroid to background ratio less than 11. That kind of really shows the difference. So that's what we end up doing. We break them into those categories, fudge a little bit. If they're like 10.5 by the hand, we go, it's close to 7. End up doing 7. We're getting about a 98% success rate. I would say that 99 is pretty optimistic, probably more like 98. And the one that we're actually retreating on Monday, we warned the owners. We said this cat's probably going to fail. We gave it 7 because we don't have the third population. Thyroid to background ratio was 40. We looked at it and said, I think this cat's going to fail. It failed. And then we're going to do a rescan, and it's going to be half the size of the normal. But that's the thing, is that now we can call them beforehand and say, look, cats fail. We could do a second dose if you want to do a second dose. And we let them know. We anticipated what was going to happen. They understood. They were fine with it. And we just charged them for the treatment as if it was going to be 2 doses in a row. Because we told them beforehand, hey, your cat can stay for an extra week. You can do it more of a high dose if you want, or you can run the risk and we'll just charge you the difference. On the flip side, if the cat is, we don't anticipate it being a failure, and it is a failure, we end up doing the retreatment for a no charge, or we give them $500 back, because we feel that confident in terms of that we're going to look at this data and tell them which way to go.
So you dose them like 1 week and then the next week if they're that big?
Or if they're a carcinoma, yeah. We'll dose them on Monday, and then we'll dose them again another Monday. Or if they really just like hanging out.
Do you run a machine scan to determine whether it worked or not, or how do you determine whether you get your responses by measuring?
T4. T4 is it, and then we will, when we have a failure, they always come back, and when they come back, and we do another thyroid scan, because that's data we want to find out what happened. Is there another part that popped up, or is it just smaller? And every one of them, without a doubt, they've all just gotten half the size. That's what ends up happening. It kills the side first, and then it gets to the center. So
how long does it take for the T4 to drop after the treatment? Is it immediate, or?
Usually a month.
A month, okay.
Yeah. It starts to taper down, but it usually takes a month, and then at 3 months it keeps going. It comes back up. And then also we have one cat that still T4 is a little bit high, but it's acting normal. We'll just wait it out. A lot of it's clinical signs. The other thing people asked is, if you give them a higher dose, well, don't you have an increase in permanent hypothyroidism? So we went back and looked at this data, and actually the cats that had the higher incidence of hypothyroidism were these. They had a smaller thyroid. They actually probably need less of a dose, but I'm not going to do that study. But someone else can if they want to. So what we tell owners, and this is important when they say, okay, well, what am I supposed to do? And you should know about this, because I'll call, I'm scared, I'm freaked out about the radiation. It's like going on an airplane in terms of the amount of radiation exposure. But my feeling is any extra radiation exposure is not worth it, so try and limit your time. So tell owners 20 minutes per day, close contact, that's it. Okay? Gloves whenever they're handling the litter, and there actually is a distribution of this. It gets excreted initially, and then some of it gets stored, and then it gets excreted again after about 2 weeks. So they got to be very careful, stay with that for the full 2 weeks. All right, in the feces. So wear gloves when scooping, no cat sleeping with you on your head during the night, that kind of stuff. Seems to be the one thing that everyone wants. My cat sleeps with me. I'm like, no, not for the next few weeks. I'm sorry. And then we recommend that they come back to you all for the 1, 3, 6, and 12-month post-treatments. If they're having anything going on, their T4 is not dropping, or the BUN creatinine are going up, we'll recommend they come in 1, 2, 3, 4, just depending on what things are looking like. We'll follow the trends in all of that. So you don't have, these are not hard and fast, these are just the guidelines to start with, and if you see things changing, of course, check them sooner. We end up sending out a card for you and just say, go see your veterinarian to go get this done. We send it to owners. And all we ask is that we get the data back so we can track everything. So post-treatment, the GFR will decrease and pretty much, if the T4 stabilizes at 1 month, which it doesn't, but it usually takes about, whenever the T4 stabilizes, it's pretty much, we give it a month and that's where it's going to be. The hypothyroid cats are more likely if they have bilateral disease, and I don't worry too much about it at 3 months unless the cat's BUN and creatinine are up. Then I start to treat. Oh, it's siloxane. At 6 months is when we're thinking that they're more permanent, and we start to talk about doing siloxane. And that they can compound that in a liquid and put it on their food. They can skip a dose. It's not a big deal. Post-treatment, we have a small percentage of recurrence, usually after 2 years. The renal, the hypertension, you know, everyone looks at that and goes, oh, the cat's hypertensive. It's the hyperthyroidism. It's actually not. More cats are hypertensive post-treatment than they are pre, because their renal disease is unmasked. So if you're going to get a blood pressure, if you have to only get one blood pressure, get it after the cat's euthyroid, not before. Unless there's retinal hemorrhages, then get it before, of course. But this really is, they get hypertensive after treatment because their renal insufficiency starts to show up. And we can see progression of those cardiac changes. Some of the other things we've seen, severe anemia post-treatment, it probably was some weird reaction. And there was a pleural effusion because the tissue, the mediastinum, it must have caused pleuritis. So some strange things do happen. So I'm going to use that to hand off to the dog. I'm just going to talk very quickly about how we're doing on time. Okay. How's everyone feeling? Okay, good. I'm going to talk real quick about the canine thyroid tumors, the breeds, the Goldens, the Beagles, and the Boxers, the age, 9 to 10 years. The dog's hypothyroid. When the dog is normal, it's hypo, but what I guess I'm saying in here is that even a hypothyroid dog can have a thyroid tumor, and I don't know how you'd ever feel one on here. This is the important part. Canine thyroid tumors, 80 to 90% malignant, and by the they really spread very quickly. So if you feel a lump in there, get on it early on that. They're really malignant, really aggressive. It's total opposite than cats. Cats, 98% of them are benign. You can on with them. You can do the tapazole. You can do the YD. You can, you can do all these things because you're not going to have something that's going to spread and pretty much go everywhere. Canine thyroid tumors, don't dick around with these. Get them out quick. So this is what we're looking at is on a thyroid scan. So this is a normal thyroid. Actually, this part right here is the tumor up cranially. It would be normal if it was exactly symmetric. There's a little tumor. Most of the time, canine thyroid tumors are what are called non-functional. When we talk about non-functional, it's either they don't secrete T4 or they don't take up technetium. There's 2 times we talk about it. Why is that important? Because if they don't secrete T4, but some reason they're taking up technetium, then they can actually be treated with I-131. If they don't take up technetium, then probably they can't do iodine therapy at all. We don't do iodine therapy here. It's done up in Tustin, but a lot of these guys are non-functional in both the production of T4 and in terms of their uptake of technetium. But still end up looking and saying we can get the information in terms of if it's functional or not on a thyroid scan. So it's always good to do. Always do screening, the neck ultrasound, the chest radiographs. And if you really want to know, is this thing going to be responsive to I-131 therapy, you can do what's called an I-123 scan, which is a cousin of I-131, and the animal gets injected with I-123, stays overnight, and then it actually looks at not only the uptake but the organification of the iodine. And we have done one cat that was negative but had a high T4. Technetium scan was completely boring, couldn't find a source. Did I-123. It was a piece of the tissue that was still secreting and putting it into fluid, but it took 24 hours for it to put enough in there to be visible, and so it's still functional. But this is kind of a zebra to do that study.
131's half-life's around 8 days or so.
I think 6.9, or you might be right.
What's the 123? Is it much shorter?
Oh yeah, much shorter. Yeah, it's like 6 hours, a little over 6 hours. I think that tech, it's probably, I'd have to look it up, but the animals get released the next day versus cats have to stay for 5 days. CT, We don't actually have to use contrast a lot of times. This one does have contrast, but the thyroid itself on CT is more hyperattenuating because of the iodine. But in a CT study, if you say, hey, I got a thyroid tumor and I want to look at it and image it, I'm not going to recommend they do, if they're going to do I-131 therapy at all, I'm not going to recommend they do contrast, because once you give iodinated contrast to a tumor that's taking it up, you have to wait 60 days before you can do I-131 therapy, because this thing's completely saturated now with iodine. So it'll block every receptor. So a lot of times what I'll end up recommending is, if you need to know what's going on, you can't pick it up on ultrasound, do an MRI, get your landmarks there, do the surgery, and then you can follow up with I-131 therapy or radiation therapy. Radiation therapy, not going to be affected by giving iodine. I-131 will be affected by giving iodine. It's such a huge dose of iodine. They will not take it up, 60-day washout. That's the tumor. So surgery, get it out, debulk it quickly, and if it's active, functional, in that it's taking up technetium, you want to really talk about I-131, because it's going to kill every cell that takes up iodine. It doesn't just the ones that you can see from surgery, it's the stuff that you can't see. If it's going to take it up, and they're all coming from one cell, right? It's a population of one cell that has the same characteristics that just is multiplying. So if one bit of it takes it up, all of them will take it up. And so if it's in the lungs, you'll kill it there too. So it's really worthwhile doing, because it's a tumor, and it's all coming from one cell. Starts at one cell that doubles, 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 doubles. And so they're all going to do the same exact thing. And then post, monitor with a technetium scan, because again, if you see it pre and then you do treatment, post, you're going to see if it's coming back, because it's going to take it up. Cells are going to come back, same activity, same way they're going to work. You all know how to get in touch with me. Ooh.